Good morning, friends and colleagues across the globe. Pavel Krastev, DDS, New Hyde Park, New York, here with you today. On behalf of the Global Summit Organization, Dr. Shah, and myself, I welcome all of you, and I thank you for being here today. I'd like to make a couple of announcements. Before we get into our show, we have a very exciting show today, and then we have another one that I'm so happy and proud to host following this one, that I hope you guys will join us also. But on a different note, the VGO man became an uncle. We had a beautiful baby girl join our family, Madeline Rose. And due to this, unfortunately, I have to apologize to the audience and to the organization. I couldn't make the book signing ceremony with Dr. Emily Letran and Dr. Shah and Dr. Julio and the whole team, which took place in Miami in the Action to Win seminar over the last few days. So my apologies, but duties called and the due date of the baby just happened to fall right while this was going on. So congratulations to the launch of the D2D new book. And I hope all of you guys get a copy. It took a lot of effort, and there's a lot of experience being shared with those of you who choose to purchase the book and read it. On a different note, today I was going to wear this very special shirt, which was given to me by a dear friend, Dr. Robert Pick. You know, Dr. Robert Pick is the gentleman that does the Purple Cow Wow team. And he's a very great speaker, a great guy who believes in practicing the profession very ethically and morally. And he loves to share his knowledge. And he's doing a great show this Tuesday coming up with the Purple Cow Wow team, which I invite you guys to join. And it's going to be a great show on case acceptance. And I think that's a very important topic that all of us can learn from. So anyhow, I had this beautiful shirt he sent me. And I had some anxiety this morning. You know, you guys know I have stage fright when I do the show. So I'm walking around the yard, and all of a sudden a bird decided to poop on me. So I guess today, you know what they say, when a bird poops on you, it's good luck. So I guess today's my lucky day. After all, as you guys can see, I am honored to host two beautiful young ladies and two aspiring dental professionals that are going to lecture on two different topics that I find I know very little about myself. And I've seen very teasers of their presentations, and I assure you they're both wonderful. So it's going to be very exciting. On a different note, you know, I want to salute all of you doctors out there, all of you healthcare professionals, because the globe as we see it and life as we knew it, things are different now. There's a lot of turbulence going around, and there's a lot of political differences, but that's not what we are here for. As doctors, I strongly believe that we come together and we need to serve as role models to society and to the globe, and to provide the necessary strength that we as doctors have pledged to do to our patients and to healthcare in general. So really, it's very touching and very, you know, I get very emotional when I think about the fact that Dr. Shah pioneered this movement. And it's taken off so strongly, thanks to all of you and thanks to our audience, to gapping and to bridging us together and closer, and sharing knowledge and sharing data, and most importantly, coming together to help one another, to help the globe, and to help people. So I salute you for that, and I thank you for that from the bottom of my heart. Also, in 2 weeks, on July 25th, I will be very honored to host our third HEX Commission meeting, where I will have time to have some of our commissioners join us, and we'll update you on some of the current and pending important aspects in healthcare and dentistry, and what is going on in the world, and how we need to again come together and and essentially keep our industry under our control, and take care of ourselves from within. So that's coming up. I hope you guys will all join us. So anyhow, so Boss Lady, finally, before we get into the show, Boss Lady, my wife, is so excited over her niece that she's really considering trying to have another baby. So just in case you guys see me losing 20, 30 pounds in the next couple of months, you know why. It means I'm working hard. Don't keep your fingers crossed, but you never know. Now, I don't want you all going out there and getting pregnant at the same time. All right, so keep it cool. All right, so guys, let's focus now our attention to our first speaker of the day, Dr. Lean Druby from Syria. Hi, Dr. Lean, how are you? And welcome to the show.
Hello, Dr. Pavel. My name is Lean Druby. I'm doing a master's degree in pediatric dentistry at Damascus University. And I'm working on my research paper. It's about evaluation of the effectivenesses of customized handle toothbrush in healthy children and children with Down syndrome between age 6 and 9 years old. Within 3 months, I'm going to finish my specialty program.
That's very exciting. And in getting to know you before the show, I realized that your father is a dentist, and your brother is becoming a dentist. And I gotta tell you, that's it's my dream to see my daughters, at least maybe one of them, if I'm lucky and fortunate enough to have one of them follow in my footsteps. But your father and your mom, I'm sure, must be so proud to to have their children essentially following in their footsteps. I mean, that's fantastic. So tell us a little bit about yourself. We'd love to get to know you. Tell us a bit what motivated you to become a dentist, and also what motivated you to go into pediatric dentistry, which I find to be a very challenging specialty in our profession, because dealing with the little brats is at times, it's not easy. There's a saying that we have in the USA. Babies, when they're small, they're so cute, you want to eat them. Then when they grow up, you regret that you didn't eat them, if you know what I mean. Because I have two beautiful daughters, Paulina and Mela, and they're changing so much each week that my wife and I often miss the days when they were small and innocent, and now they talk back to you. So it's challenging. But yeah, tell us a little bit about what motivated you.
It's difficult, but I have the passion for pediatric dentistry. Even when I was in my teens age, I'd love to help and work with children. And my role model in life, who is my father, he is a dentist. He made me love and enjoy dentistry. So to combine my passion toward children and being a dentist, I have chosen to become a pediatric dentist so I can enjoy what I do. But I have an advice. If anyone wants to be a pediatric dentist, be sure don't get into pediatric unless you are really love what you do.
Yeah, that's a great point you bring, and that kind of leads me to mention another thing that I think is very important in dentistry and in healthcare in general. Medicine is so broad, dentistry is so broad, that it's very difficult to become an expert in every single aspect of what you can do professionally. So that's why I highly always recommend to younger colleagues, when they start out, pick an area of interest. It may be implantology, it may be crown and bridge, it may be aesthetic dentistry and ceramic veneers, or pediatric, whatever. Find your niche, find your calling as to what you enjoy, and then become better and better at it. And that's how you will have a quality practice where you will literally achieve miracles in terms of your ability, because with the years, the knowledge base and the skill sets become more extended. And it's just the key, in my opinion, for long-term success. So Wonderful. Let me read your resume to our audience, and then I'd like to slowly get into the presentation. It's a very exciting presentation, as I said earlier, which, pediatric dentistry, unfortunately, I know very little about these days because I don't practice it. Do I remove deciduous teeth? Yes. But aside from that, I really do my best with my office manager and my wife to really refer out that kind of work. And another thing that's leads me to this conversation leads me to mention is there's nothing wrong with all of us knowing our limits. And I believe we owe it to our patients to know what we are very good at. We can do essentially to these standards that a specialist will go to. And the rest of the things, there's nothing wrong with referring out. I certainly work with a team of oral surgeons, endodontists, pediatric dentists. So I always, if I can't do it, I'd like to refer that patient to someone that can do it better than I will. And I highly recommend that our younger colleagues learn that there's nothing wrong with working as a team and working together. But anyhow, let me read your resume to our friends, and then we'll get started.
Yeah.
Okay, Dr. Druby received her DDS degree from Damascus University, Faculty of Dental Medicine in 2017. Currently, she is enrolled in a 4-year master's degree program in pediatric dentistry at Damascus University. Dr. Druby is doing a research paper in her master's about evaluation of the effectiveness of a customized handle toothbrush in dental plaque control in healthy children and children with Down syndrome, a randomized controlled trial. She has conducted a survey of 538 parents to evaluate the parents' knowledge of the effectiveness of toothbrushing in children. The survey was approved for publishing from the Damascus University Journal of Medicine of Medical Sciences. Dr. Druby practices pediatric dentistry in the Druby Dental Clinic, as well as in the Department of Pediatric Dentistry at Damascus University, where she works with the currently enrolled dental students. In addition, she is a contributor to many awareness programs for children and oral health. Dr. Druby offers comprehensive treatments for patients ages ranging from 1 day to 17 years old, as well as special needs patients of all ages. She possesses the necessary skills in procedures, behavior management, and simultaneously offers support to patients with dental phobias. Traumatic injuries are a specialty that Dr. Druby has long and invaluable experience in treating. She takes continuing education courses to stay current with the latest advances in dentistry. Dr. Druby's passion lies in treating her patients in the gentlest way possible. With the help of the latest technologies, she can improve the patient's dental health, appearance, and self-esteem. In her free time, Dr. Druby enjoys spending time with her family, friends, and cooking. Man, I love to eat. So if I come to Syria, I'm coming over. All right, Dr. Druby. So I'd like to turn over the show to you. And I look forward to you sharing your wonderful presentation with us and myself and the audience. So the floor is all yours. And at the end, I'll see you at the end, and we'll take some questions and maybe have a little discussion. Okay.
Okay. Hello, everyone, and thank you so much, Dr. Pavel, for introducing me. It's my pleasure to join this global platform and have the opportunity to share my clinical cases. Today, I'm going to present some of traumatic dental injuries cases in permanent dentition. In the last 4 years and during my specialty program at Damascus University, I have the opportunity to manage and treat big numbers of dental trauma cases. Within this short period of time, I was able to treat simple and complicated traumatic injuries, which made me appreciate how difficult and challenging it can be to manage and treat children with traumatic dental injuries. So let me move to the presentation. Traumatic dental injuries in children and adolescents are considered a significant public health problem worldwide. The management of traumatic dental injuries is a big challenge, especially for pediatric dentists. Experiencing traumatic dental injuries during childhood can have a negative impact on children and parents' quality of life, affecting their growth, socialization, self-esteem, and learning abilities. The incidence of traumatic dental injuries. Cause of injuries. The most common cause of dental injuries is falls. Sport-related injuries are generally the second most common cause of dental injury. Occurrence of injuries. Traumatic dental injuries occur with great frequency in preschool, school-age children, and young adults, comprising 5% of all bodily injuries. Injuries to primary teeth tend to happen more at home, whereas injuries to permanent teeth tend to occur most often outdoors. Age and gender significance in injuries. Oral injuries are most frequent during the first 10 years of life, decreasing gradually with age and very rare after the age of 30. In primary dentition, traumatic dental injuries rate are equal for both genders, whereas in permanent dentition, traumatic dental injuries rate are higher in males than females. Type of injury. Luxation injuries are the most common traumatic dental injuries in primary dentition, whereas the crown fracture are more commonly reported for the permanent dentition. Picture on the left shows intrusive luxation in primary dentition, and picture on the right show an uncomplicated crown fracture in permanent dentition. Location in dental injury. The maxillary central incisor are the most common traumatized teeth. And there is many predetermining factors. An increased overjet was significantly associated with higher odds of developing trauma in all dentition stages and age groups. Orthodontic appliance and general anesthesia. What, how, when, where, and how. The main 5 questions to review patient traumatic history. What was patient doing that led to trauma? How did trauma occur? When the injuries occurred, minutes, hours, and days. When is an important to determine the necessity of treatment and to assess the future prognosis of treatment. Time between the trauma and treatment plays a major role in dental evolution and luxation cases. Where the trauma occurred, location, clean or dirty. Where can provide useful information as the degree of bacterial contamination and the need of tetanus prophylaxis. Who witnessed the traumatic incident? The main goals of treatment is to maintain vitality of pulp and periodontal ligament. Successful outcome noted when tooth is asymptomatic, tooth has positive response to pulp sensibility testing, root has continued root development in mature teeth, normal mobility, and no periapical pathology. Traumatic dental injuries in primary dentition can be divided into 5 categories. In this presentation, we are going to discuss cases related to uncomplicated crown fracture, complicated crown fracture, and root fracture, and subluxation, lateral luxation, and intrusive luxation. Here's the case number 1. Case presentation. A 7-year-old female presented with multiple dental injuries due to falling. Patient presented to dental school 1 day after the trauma occurred. Patient with no significant medical history. In this intraoral picture, shows teeth number 24 and 25 and 26 are broken. And in this panoramic radiograph showing teeth number 24 and 25 and 26 with an open apex. And this periapical radiograph for tooth number 25, we can see tooth with an open apex. Clinical and radiographic examination revealed multiple traumatic injuries, including tooth number 25 had enamel dentin and complicated crown fracture with an open apex. And teeth number 24 and 25 had enamel and complicated crown fracture with an open apex. The management of this case. In this case, we have uncomplicated crown fracture and complicated crown fracture. According to International Association of Dental Traumatology guidelines, the treatment for uncomplicated crown fracture, if tooth fragment is available and intact, it can be bonded back onto the tooth, or a composite resin restoration can be placed. And there are multiple treatment options for complicated crown fracture, such as direct pulp cupping, partial pulpotomy, cervical pulpotomy, pulpectomy, and extraction. That depends on the time between the treatment and the treatment and patient when he comes, and root develop and size of pulp exposure. The management of this case, tooth number 25, as presented, 1 day after the trauma occurred with a large pulp exposure and bleeding. Treatment provided was cervical pulpotomy with MTA. Teeth number 24 and 26, indirect pulp cupping with calcium hydroxide lining was done and covered with glass enamel. All these teeth were restored with composite resin. This periapical radiograph was taken once the treatment had finished. We can see the pulpotomy for tooth number 25. In this picture, after restoring all traumatized teeth, the treatment was successful in preserving pulpal vitality and continued root development in immature teeth. The follow-up of this case. In 6 months follow-up, in this radiograph, we can notice the root development continues. And after a year of treatment, we can notice that all traumatized teeth have continued their root development. This first picture on the left was taken once the treatment had finished. And the picture on the right, after a year of follow-up, we can notice that all traumatized teeth have continued their root development. And here's the case number 2. Case presentation. A 6-year-old male presented with traumatic dental injuries because the child collided with a straight light pole. Patient presented few hours after the trauma. Patient with no significant medical history. This periapical radiograph showing teeth number 24 and 25 with an open apex. And this intraoral picture showing gingival laceration between teeth number 24 and 25. Clinical and radiographic examination revealed multiple traumatic injuries, including tooth number 25 had subluxation and it was with an open apex. Gingival laceration between teeth number 25 and 24. And alveolar fracture include buccal plate for tooth number 25. According to International Association of Dental Traumatology, the treatment for subluxation injuries varies. If no mobility or discomfort, no treatment is needed. Or if tooth is mobile and causing discomfort, the tooth can be splinted for up to 2 weeks. The management of this case. Teeth number M, 24 and 25 and R were splinted with flexible splint using 0.7 orthodontic wire and composite resin for 4 weeks. This periapical radiograph showing splinted teeth with orthodontic wire and composite resin. And this intraoral picture was taken after removing the splint. Shows healed soft tissues. And periapical radiograph after 6 months shows teeth number 24 and 25 have continued their root development. And this intraoral picture after 6 months. In this case, successful outcome noted because tooth is asymptomatic and the tooth had positive response for sensibility testing. Now let's move to the case number 3. In this case, I'm going to present combination of 2 injuries that occurred simultaneously. The combination of 2 different types of injuries occurring concurrently to the same tooth will become more detrimental than a single injury and creating a negative synergistic effect. Case presentation. A 9-year-old female presented with complicated traumatic dental injuries due to falling on her face and hitting a ceramic bar. Patient came to the clinic 6 days after the trauma had occurred. Patient had already been seen by a general dentist. 1 day after the injury occurred, the general dentist extracted loose and broken coronal fragment of tooth number 7. That was the only treatment possible at time, due to the patient's lack of cooperation. After conducting an interview with the patient's parents, the patient was healthy with no remarkable medical history. She didn't experience any nausea, loss of consciousness, or vomiting after the trauma. Patient's vaccination was complete. Intraoral picture shows a frontal view of traumatized region with severe gingival laceration. And intraoral picture shows an occlusal view of traumatized region. And this panoramic radiograph was taken with 24 hours after the trauma. We can see the coronal fragment for tooth number 7 before general dentist extracted it. Here is the tooth number 7. And we can notice intruded tooth number 9. And this periapical radiograph for intruded tooth number 9. Clinical and radiographic examination revealed multiple traumatic injuries, including tooth number 7, horizontal root fracture in the coronal third of root. Fracture line was located 1 millimeter below alveolar crest level. Tooth with an open apex. Tooth number 8, lateral luxation to palatal direction with an enamel dentine and complicated crown fracture. Tooth with an open apex. And tooth number 9, intruded luxation beyond 7 mm with an enamel dentine and complicated crown fracture. Tooth with a closed apex. And tooth number 10, enamel dentine and complicated crown fracture. Laceration were presented on the periodontal tissue surrounding teeth number 8 and 9. In addition, alveolar fracture and patient tongue and palate were covered with pseudomembranous candidiasis. Patient had mixed dentition and caries lesion on teeth number A, B, I, J, S, T, and tooth number K had periapical abscess. How to manage this case? According to International Association of Dental Traumatology, the treatment for root fracture depends on the fracture line location. If the fracture line was located in the coronal third, first reposition fragment as soon as possible, then check position radiographically. After that, stabilize coronal fragment with flexible splint for up to 4 months. If the coronal fragment is very mobile in mature tooth, remove the coronal fragment, followed by root canal treatment and restoration with post and retained crown. And if the fracture line was located in the middle root, reposition fragment if displaced as soon as possible, then check position radiographically. After that, stabilize coronal fragment with flexible splint for up to 4 weeks. And if the fracture line was located in the apical root, if coronal segment is mobile, reposition and splint for 4 weeks. If coronal segment is not mobile, no stabilization is needed. And the treatment for lateral luxation treatment includes reposition with finger pressure and flexible splint for 4 weeks. Sometimes root canal treatment might be needed if pulp becomes necrotic. And the treatment for intruded tooth with closed apex. If the intrusion is less than 3 mm, allow re-eruption without intervention. If no re-eruption with 8 weeks, reposition surgically and splint for 4 weeks with passive and flexible splint, or reposition orthodontically before ankylosis develops. Or if the intrusion is between 3 and 7 mm, reposition surgically or orthodontically. Or if intruded tooth beyond 7 mm, reposition surgically. In teeth with complete root formation, the pulp almost always becomes necrotic. Root canal treatment should be started at 2 weeks or as soon as the position of the tooth allows. In first visit, patient mouth was rinsed with saline and chlorhexidine. Local anesthesia administered by filtration using 2 carpels of 1% lidocaine with epinephrine in the location of the traumatized teeth. Then, tooth number 9 with a closed apex had intruded beyond 7 mm and was surgically repositioned into optimal position. Using forceps, tooth was loosed and extruded into final position. Tooth number 8 was repositioned by applying finger pressure. After that, gingiva sutured and teeth were stabilized with a splint. The splint was made with 0.7 orthodontic wire and composite resin. Splint was attached into the labial surfaces of involved teeth, number C9, 10, 11, and H, for 4 weeks. Tooth number 7 had a root fracture and no treatment was done in this visit. In this picture, we can see teeth number 8 and 9 after surgically reposition and after gingiva suture. Next picture, we can see the splinted teeth. Patient was given antibiotic and antifungal prescription. Patient was advised to rinse twice a day with an antibacterial agent. After a week, sutures were removed. Intraoral exam revealed no signs of candidiasis infection on the tongue or palate. Both teeth, number 8 and 9, tested negative for vitality test. This periapical radiograph after 2 weeks for tooth number 8 and 9. After 2 weeks, root canal treatment for teeth number 8 and 9 was initiated. Pulpotomy was done, and canals were filled with calcium hydroxide, and GIC used as temporary fillings. After 4 weeks, before removing splint, root canal treatment for tooth number 9 was complete. Canal filled with cottapercha. And for tooth number 8, had an open apex, MTA used to form apical plug, and remaining root canal was filled with cottapercha. In this case, I used MTA plug as an apical plug because there are no apical stop. And this intraoral picture shows an occlusal view of traumatized region 4 weeks after the trauma. We can notice palatal soft tissues healing. After splint removal, teeth number 8 and 9 and 10 were restored with composite resin. Teeth number 8 and B, I, J, L, S, and T were restored with stainless steel crowns after pulpotomy. Fissure sealant were applied for teeth number 3, 14, 19, and 30. Tooth number 7 was monitored with no intervention for 10 months until apex is closed. Then tooth was surgically exposed in order to have a root canal treatment. Tooth was restored with post and core and porcelain fused metal crown. This periapical radiograph shows continued root development for tooth number 7. And here's the treatment provided for tooth number 7. Post and core was made after an impression was taken with acrylic resin and sent into the laboratory. Post and core manufactured using CAD and CAM. Follow-up. 1 year follow-up, occlusal view. And 1 year follow-up for the frontal view. this picture after 1 year, and this picture after 2 years. And lastly, one small thing I'd always like to remind parents with: how to manage effulgent tooth injury. Unfortunately, I had a patient last month presented after traumatic injury to tooth number 9. Parents decide to throw away a vault tooth, which could be possibly saved if properly managed. So, according to International Association of Dental Traumatology, what to do if your tooth is knocked out? First, find the tooth. Then, hold it by the crown. Next, rinse in cold tap water. After that, if possible, put the tooth back in its place, or follow one of these alternatives. Place the tooth in a cup of milk or saline. When milk is not available, place the tooth in the mouth between the cheek and gum. Finally, seek immediately specialized dental treatment within 2 hours time period. Traumatic injuries to the dentition are difficult to anticipate. However, exercising of good judgment and prevention is the best defense. And thank you so much for your listening.
Hi, guys. I can't see myself. Can everyone hear me? Dr. Lean, can you hear me?
Yes, I can hear you, but I can't see you.
Oh, here we go. Okay, I'm back. So anyhow, that was extremely interesting for me, at least, because as I said, I'm a general practitioner. I mean, I don't really treat this type of scenarios unless something strolls in on a complete emergency basis. And certainly now, after watching your lovely presentation, I am more confident that I will be able to manage if I'm faced with such a case that walks into my office. So that was really exciting. I personally have a couple of questions that I wrote down that I like to bring up. For example, when you decide when this traumatic injury that you're dealing with must be referred to an oral surgeon. In other words, do you see cases where, unfortunately, a child comes into you with buccal bone displaced with the tooth in it? Are you faced with challenges where you actually have to open a flap and reposition a tooth with a segment of bone attached to it? When is the what is the protocol with something like that?
In this case, we are working like group with surgeon doctors and with pediatric.
So you work as a team.
Yeah, we work like a team. In the third case, we work such a team. 3 doctors work in this case.
Another question that I want to ask, and it may sound sort of rhetorical, but when it comes to frenectomies, when do you guys recommend to remove a frenectomy? I mean, excuse me, when you to do a frenectomy when you have a pronounced frenulum, especially in the upper anterior, and when you just leave it, what is something that we can learn as a general guideline of how we prevent diastemas from forming due to excessive muscle pull? Can you tell us a bit about that? Now that I figured I have a pediatric dentist, I want to pick your brain a little bit.
Actually, always I keep on reading the International Association of Dental Traumatology. and I put the guidelines in my clinic, and I keep on read it and read it. So
wonderful, wonderful. And then I'm going to ask a real silly question now. Stainless steel crowns. You know, when I graduated school in 1993, back then we had no electricity. You know, I mean, these days I still run my office. We use candles in my office. We run on candle power. You know, I'm old school. So what I remember learning about pediatric dentistry and treating teeth with stainless steel crowns, I'm almost assuming with certainty that the technology and the techniques have changed. So can you tell us a little bit about, I mean, do we still make stainless steel crowns the same way? We, you know, reduce the tooth, cut a crown with the scissor and slap it on with cement? Or these days with CAD/CAM technologies and computers, where they've gone, do you guys do different techniques?
Actually, in Syria, we always use the stainless steel crown, and I advise the parents to put this crown because it's the best. I think it's the best restorative for permanent dentition, for primary dentition. Now I want to try using CAD/CAM by the material. I don't know if you know it. It's named PMA. I will try it, and
Yes,
I will tell you the result.
That's I'd love to know more about that, because I mean, probably aesthetics is not a huge concern when a kid is, you know, 5, 6, 7 years old, and the stainless steel crowns, you know, probably can do. But I think with the advances of dentistry, where we're going and where we've gone over many years, the materials and products, perhaps CAD/CAM and the PMA materials and maybe even other metallics can be used in the future to mill these things at a reasonable cost to the patients. Because as we know, sometimes the stainless steel crown is there just to keep a tooth indefinitely until it's replaced by the succedaneous tooth. So yeah, that's exciting stuff. Well, Dr. Druby, let's see, do you see any questions in the comment section? Let's take some questions, guys, from the audience. Does anyone have anything that you'd like to ask Dr. Druby? Mr. Ansel, do you see any questions in the background?
1 minute.
Oh.
Let me see here on the messages if we have any. But that was really a great show. I mean, I certainly learned a lot today. And I'm very, very glad to have this opportunity. I guess we don't see any questions, ladies and gentlemen. Dr. Druby, on behalf of Global Summits, once again, I'd like to thank you for this wonderful presentation. I'd like to also express a sincere, heartfelt thank you to our audience for joining us today. We always invite you to stay with us. Don't change the dial. We have many, many great plans for the future, and we'd love to have some of you join us in the DHB program. It's a 2-year program that will be given by healthcare providers for healthcare providers. So I encourage anyone from around the world to consider getting this doctorate degree in addition to your current degree that you possess. And that certainly will open new doors for all of you who take our program, because you will learn to streamline your financial aspects of your careers. You will learn how to innovate and perhaps channel some of your spare time into that aspect in your futures. And of course, you will certainly have very well given courses from experts on practice management and financial aspects. So I would invite all of you to look into it. And last note, I guess I would like to salute and congratulate the top 100 that were recently published. You guys all have worked very hard, very diligently, and thank you. Global Summits, as you all know, is an organization that shares knowledge, that pioneered the D2D or doctor-to-doctor movement. And our mission is to unite healthcare professionals across the entire globe to come together, represent society and be role models for others. And it's up to us, doctors and healthcare providers, to unite everyone, to love everyone, to care for one another. This is what we're here for, and this is what we do all day. So I thank you all for that. And I guess we'll call it a show. Thank you once again. And
thank you.
Everyone gets the video kiss today. Love you all. See you guys in the next show. Bye.